Good morning, everybody. We are discussing about osteomyelitis. In this topic, we are going to consider about the pathology, microbiology, classifications, clinical features, and radiographic investigations, treatment options like medical and surgical management, and also we are discussing about the osteoradionecrosis. What do you mean by infection? It's the lodgement and multiplication of organisms in or on the tissue of a host constitutes. So, what do you mean by osteomyelitis? Osteomyelitis is the inflammation of the bone marrow with a tendency to progression involving the cortical plates and often the periosteal tissue. So, how will you establish an infection? Most might be three factors like the host, the agent, and the environmental factors. Mainly, the microbial factors will be less and the host factors will be high, so we can fight against the foreign body. The host factors are three types mainly by the local, humoral, and cellular. The local factors like the skin and the mucous membrane, by the, like the epithelial lining, secretion and drainage, microbial flora, and mucous immune system. So if there will be any problem in that area, that will microbial organism enters and leads to infection. The humoral by the immunoglobulin and complement. Immunoglobulin like our IgG, IgM like that. So that fatty barrier observing and leads to phagocytosis. Complemented by the chemofatty factor observing analysis that also killing and leads to phagocytosis. Cellular by the lymphocytes and the phagocytes killing killer cells. Phagocytes by the phagocytes the adhere and the locomotion of chemocytes that leads to phagocytosis. If this any problem happen to the local humoral and cellular, that leads to the entering of the microbial organism. So the dental infection by two types, acute and chronic infection. Acute is a sharp shooting type of pain and chronic is a dull ache type of pain. The types of infections like fistula, cellulitis, intraoral soft tissue abscess, osteomyelitis, bacterial septicemia, disfacial space infection, and facial sepal infections. So, the osteomyelitis is an inflammatory condition of the bone that begins as the infection of medullary cavity and nervous system of the cortex, extends to the involvement of periosteum and the affected area. There are two types, mainly infection and inflammation. Inflammation is mainly produced from our body, and infection is to the foreign body. So the main etiological factors for the osteomyelitis infection is like bacteremia, viral, fungal, and protozoal, or head and neck infection like bacterial, or odontogenic infection, or leads to any trauma, or infection derived by the hematogenous route. The pathogenesis mode of the spread and how the infection will be established. Mainly the hematological and continuous focus. So the pathogenesis is first the infection starts like acute inflammation in the bone marrow. So what will happen? The inflammation will starts that will leads to increase intramedullary pressure. So automatically the intramedullary pressure will increase. What will happen? There will be vascularity in the bone marrow, means in the nervous system. So what the vascular collapse will happen. If there will be a vascular happen, there will be poor deficiency of blood. So that will be avascularity of the bone. So avascularity of the bone will happen. So what will happen? There will be a pus or microbial organism will grow in a poor oxygen supply. Poor oxygen supply. So microbial organism will develop. So it will multiply, and what will happen? It will take all the uh, affect the Haversian system into the canal involvement. So that will leads to the elevation of the periosteum, and it will disrupt the blood supply and leads to the necrotic bone because there will be no vascularity in the Haversian system. our body will fight against the microbial organism, but if there will be microorganisms will more increase, so what will happen? The virulence quantity will be high. So the predisposing factors. It is for a compromised patient, immunocompromised like diabetes, malnutrition, agranulocytosis, anemia, leukemia, sickle cell disease, steroid drugs for a long-term procedure, cancer chemotherapy, AIDS or HIV, syphilis, or tobacco and alcohol. This type of patients have a chances are more. And the avascularity of the bone in addition of causes basic disease of failure of and nervous dysplasia, cementoosseous dysplasia, bone malignancies, or bismuth or arsenic or mercury poisoning. This type of causes that leads to avascularity of the bone. So the classification of osteomyelitis mainly by acute and chronic are there. Before that, we can tell it's a suppurative osteomyelitis or non-suppurative osteomyelitis. In acute suppurative and non-suppurative, progressive or hemogeneous. Chronic by primary chronic osteomyelitis, gyrus osteomyelitis, suppurative or non-suppurative, or sclerosing focal or generalized osteomyelitis. So, the osteoradionecrosis also leads to non-suppurative osteomyelitis. Acute suppurative. Acute suppurative, it's earliest acute now. It's a deep intense pain. The fever will be around 101 to 102 degree Fahrenheit, and paresthesia will be there, and also indifferent pose. What we'll do for an acute case? No, immediately hospitalization and aggressive antibiotic therapy. Might be it will give for around 2 weeks, and also there will be swelling, cellulitis, dehydration, and loosening of the teeth. If you check, maybe patient will be pain, swelling, lymphadenopathy, fever, paresthesia of failure nerve. The clinical sign, trismus will be there, and also malaise. For a chronic osteomyelitis cases, the pain less intensive, pyrexia less severe, anesthesia is uncommon because already the acute stage finish. That's why loosen of the teeth and to the adjacent teeth, and there will be sinus tract onto the skin because the pus will discharge to the extraoral. Next one is the infantile osteomyelitis. Infantile weeks after the birth, perinatal trauma to the oral mucosa by finger or suction, but maxilla more commonly affected in infantile osteomyelitis. So features like irritability, fever, anorexia, dehydration, convulsion, vomiting, and suppression from the nostrils. Diffuse sclerosing osteomyelitis. It's also in the age may raise, at least we can see any age, commonly seen on the middle age, and it's the pain, swelling, and acute acceleration, mandible, basal bone, and the alveolus may involve the ankle, ramus, and condyle. Might be we can see on a unilateral or sometimes also. Focal sclerosing osteomyelitis is seen in the young age, average of 14 years, more common in the long ones, mandible, second or first molar, second premolar, and also it is a asymptomatic. So, what are the managements for a osteomyelitis? There are two management: medical management and surgical management. So, in medical management, we are normally using the antibiotics. Surgical meaning for the surgical removal. So first of all, we want to evaluate the host response. and check about the gram staining and culture sensitivity, imaging studies, PET scan like that. Administration of stain guided antibiotics, loose tooth removal and superficial sequestrectomy, culture guided antibiotic administration, post replacement irrigating drains and antibiotics. Treat surgically and support medically. So the evaluation of the postman, suppose I already told about, there are two things mainly that compromise thing and vascularity of the bone. Compromise mainly the diabetes, steroid long time steroid cancer, chemotherapy or radiotherapy, and malnutrition, alcoholism, and disease. So you have to evaluate all these things. So we'll go for first of all the image. What are the radiographic investigations we do? Mainly the extent and degree of the local disease and planning. Then only we can go for what type of treatment we need. So normally the conventional radiograph, radionuclide bone scan. Right. Conventional also we are telling about the OPG, occlusal films, lateral oblique view, PNS view, like that. So for the chronic osteomyelitis, the radiography features like scattered areas of the bone restriction varying in size. Because chronic is normally the area will be dissected and there will be signs of pathological fracture and also sometimes there will be sinus tract to extraorally. And also we can see in the radiographs there will be mouth eaten appearance and a bony secretion and or densification of the bone due to the subperiosteal or intra-intrinsic bone deposition. So, however, mainly that bone trauma is like fibrosis, vasculitis, and the sarcomas of the bone. So we can see in the chronic osteomyelitis, we can see a mouth-eaten appearance of the bone, and will leads to a pathological fracture. See the radiograph, there will be bone fracture also we can see. And figure B, it's not leads to pathology, but chances will be there. Next one we are going for X-rays. We can see all these things. Next one, how you identify as a radionuclide bone scans. Otherwise called skeletal scintigraphy. It's nothing but we are administering the radio intravenously and the radioisotopes will absorb by the bone and after detect after might be we can take 1 day or 20 to 3 days we can see the radioisotope might be where the dissection is, it will mostly absorb on that particular area. So that means that area more commonly affected. Mostly they are using gamma 67 or T-methylene this diphosphonate commonly and commonly used in MRI. Nothing but normally we want to section the bone on a three-dimensional it will affected to a soft tissue or we want to see how much area the bone dissected. So that is a more commonly used 3D CT and the MRI. The administration of the antibiotics is mainly by the organisms Streptococci or anaerobes like Peptostreptococcus or Fusobacterium or Rotella. So, antibiotic regimen for the osteomyelitis are two types: mental, medically compromised patient, and for inpatient patients of administrative severe chronic pain type of cases, we are using that IV antibiotic. So more commonly is penicillin IV plus metronidazole 500 milligram IV 6 hours or for our daily. When it's improved in 42 to 72 hours. Otherwise, we can give a penicillin with the metronidazole or ampicillin also we can use. Sometimes we are using with the Mox Cloud 1 to 2 gram IVBA twice daily 4 to 6 weeks. If the patient is not that much affected and not environment compromised patient, it's a regimen too. It's a outpatient, no? So we can give penicillin 2 to 4 weeks, and it's we give already after the sequestrum is means the removal of the dead bone. After medical therapy, surgically, however, first you will go for the incision and drainage. If the causative axis is the tooth, no, you accept the tooth and debridement and continuous and intermittent interlinked closed catheter irrigation will do sequestrectomy, but removal of the dead bone. Saucerization is the surgical excavation of tissue to form a shallow depression to facilitate drainage from the infection areas of a bone. Then decortication removes the poorly vascularized bone but returns to well vascularized coagulation. Resection or reconstruction. Resection means we'll section the bone and reconstruct new bone or recon plates like that. Resection is a necrotic bone. Uh, Removal of the dead bone, cortical cancerous or cancerous bone, resolve respondency expel and consent. Avascular and poorly penetrates by antibiotics. So to remove the down, we will give the strong antibiotics so we can achieve the normal. So operation is the unrolling of the bone to expose the middle cavity of the for the debridement. I think what shows so just from this shallow depression, we cut it off and to facilitate the uh, drainage from the infectious areas. So, the decoration is nothing removes poorly vascularized bone but brings to the well vascularized bone. So we can achieve the normal bone. Local antibiotic therapy is nothing but it's a high local concentration with the minimal systemic levels. So infusion of that antibiotic penetrates to the particular infected area. So what will happen? All the uh, after the socialization or sequestration, what will know? The antibiotic solution will diffuse to the cell or bone, so we can achieve the reduce the infection. Next, we are going to discuss about the osteoradionecrosis. Osteoradionecrosis, mainly it is due to the cancer of the head and neck is treated by the surgery, and after that we will go for the radio or chemotherapy. Not at all head and neck, to the other parts of the body. So radiation affects both the soft tissue and so the serious and late complications seen in the oceanography is the therapeutic radiation of the head and neck cancer agent, exposure of a non-viable, non-healing, non-septic lesion in a irradiated bone. The effects of the radiation on the bone is depends on the quality and quantity of radiation. So more normally the 50 gray kills the bone cells and causes arthritis. 1500 to 7000 microgray per day to the floor of the mouth or the mandible. So what will happen? Hypovascularity, hypocellularity, hypoxia, failures of osteoclastic activity. There is deficiency of the oxygen, deficiency of the blood supply. These also leads to the dissection of the bone. So if going for a chronic non-healing wound, what will happen? There is be hypovascularity, hypocellularity, and hypoxia. Formerly, osteoradionecrosis was thought by triad like a radiation trauma and infection. So, what are the inflammatory stimulus placing the radiation breakdowns and microorganisms merely cannabinoids? So, we'll excel the tooth extraction mucosal ulcer. We can see laceration, disease, and root canal instrumentation. So the clinical features for a osteoradionecrosis is a severe, deep, boring pain from weeks to months after radiation therapy and chemotherapy. There will be soft tissue abscess and draining sinus intraorally or extraorally. Exposed bone sequestrum and osteopenic and fibrotic things. There will be extraoral or intraoral fistula we can see. Trismus fitted out because pus discharge will be there, and denoted bone can be seen alveolar process following the extraction. Mucus may showing sloughing, slow sequestration, deep cellulitis of the facial spaces. These are the common clinical features seen in the osteoarthritis. So, how will you manage a osteoradionecrotic patient? Debridement and topical antiseptic rinses. Mainly we are using with the betadine irrigation. Removal of the small sequestra, curating that area and wearing it out until the normal bleeding. Mostly what will happen, we can see there will be no vascularity. So we will debride that area. So when we can achieve the normal bleeding, that means that area become vascular. Up to that, we will debride that area and control the infection with a strong antibiotic coverage. Mostly, we'll admitted the patient in hospital and give hydration because patient will be dehydrated. So high protein diet we give, and patient pain relief, strong antibiotic and painkiller will give, and maintain the oral hygiene. That is very important. Otherwise, there will be again the chance of infection will be there. And frequent irrigation of wounds after the meals, mostly around 4 to 5 times a day. We'll irrigate with the betadine with the saline irrigation, and we giving sometimes we'll give a add of impact also. It is promote healing. So after that we'll go for the hyperbaric oxygen therapy, HPO therapy. Hyperbaric oxygen therapy is the agent of both the conservative and surgical treatment of osteoarthritis. It consists of inhaling 100% of oxygen at the elevated pressure, 2.4 or 1.5 atmosphere pressure. So it consists of 90 minutes section once a day for 30 days before the surgery and 10 days after the surgery. This therapy is used to preventive method protocol is a daily session for 20 days before and 10 days after the treatment. So what advantage for hyperbaric is to brings the oxygen to hypoxic tissue by increasing the blood tissue oxygen gradient that will favors the wound healing and process the functional reconstruction of irradiated tissue and preventing necrosis. So it's a bacteriostatic and bactericidal for many of the organisms. So it's very effective for osteoradionecrosis. It's a closed chamber, so it admits the 100% oxygen in that chamber for 30 days, around 90 minutes in a day. So after this, there is the protocol for osteoradionecrosis that's called Mark's protocol. It's nothing. it's a stage-wise procedure. Suppose if the patient came and identify about there is there it's a immunocompromised or their vascularity of the bone, everything will first identify. After that, we will stage wise. First stage, no, you'll go for 30 times 100% of oxygen for 90 minutes, 2.4 atmosphere pressure. Examine the exposed bone. If the will be a response is there, then we'll reduce into 10 times of 100% oxygen for 2.2 at home. That means the patient is responding in for the first treatment. If there will be no treatment, it will go to the stage 2. Stage 2 is first we'll go for the surgery, means it's the low border of the mandible, and after that we'll go for 10 times 100% of oxygen for 90 minutes. If it's the responding, the healing without exposure, exposed bone, that means healing started. If again there is no response after the surgery and after the treatment, we'll go for the next stage 3, excision of the non-viable bone and fixation of mandibular segments or reconstruction. And the same thing we'll figure reconstruction always do after the treatment. Suppose there will be chance of again uh, recurrence will be there. So after resection of the fixation of mandible with the reconstruction plates, and check we give a hyperbaric oxygen therapy for 10 times. Then check if there will be the bone starts healing and new healthy bone starting. We go for a reconstruction of bone for after the treatment, means 3 months later. There is no further treatment of hyperbaric oxygen therapy, and we can reconstruct the mandible using the tibia or fibula graft. So if suppose there will be initially to stage 1, no, there will be cutaneous fistula, pathological fracture, resorption of the mandible, no, then don't go for the stage 2 treatment, directly go to the stage 3. So we can achieve the normal healthy bone within months, because fracture, resorption, everything, it's a advanced stage. So what will happen, there will be it will never affect for the hyperbaric oxygen therapy. So we go for the excision and reconstruction mandible and give hyperbaric oxygen therapy and go for the reconstruction. This is called mask protocol. Radiation and dental care now known. All non-resorable teeth directly, the path of radiation should be removed. Means there will be mobility of the tooth. Means that leads to uh, infection. So that's why all the non-resorable teeth will remove. Sharp bony margins will remove, and the dental therapy give within 2 weeks. After the radiation therapy, what mainly thing the dentures should not be used for around 1 year. There will be high chances of serostomia, and topical fluids will be scaling of the tumor. So we'll give the fluoride therapy. There will be chances of caries will be there. So we give a fluoride therapy and salivary substitutes will give. And also you will give, there will be any extraction also therapy too. These are the main basic things we go for the osteoradionecrosis. Thank you. So in this topic, mostly we are concerned about the osteomyelitis, clinical features, pathology, clinical features, classifications, treatment plan, and also we will discuss about the osteoarthritis, the clinical features, what are the medical management, and also whole management by Mars protocol. After that, we'll go for after radiotherapy, what are the pre-radiation and the post-radiation treatment. We'll go for the radiotherapy patient. Thank you.